the screen. So my name is Mbengue. I'm also a cannabis nurse. I'm in graduate school working towards a master's of science in medical cannabis therapeutics. And I am doing this presentation on Tuesday at a conference for senior living executives in New Orleans. So this is a two-part presentation I'm giving. Part one goes through, kind of the stuff that Gloria went through, and part two is all about policy. So this is part two of that presentation. So all of this sounds great, but how do we actually implement this into facilities when we have conflicting federal and state laws? So this is where I'm going to go over policy. We're going to look at, terminology, hemp versus marijuana, federal versus state laws, various roles, and then employee use of cannabis and CBD. Okay. So earlier we talked about Ryan's law. Earlier I told you Ryan's story, Ryan Bartel's story. And in 2021, California kind of solved that issue. So Newsom signed into law SB 311, which is also known as Ryan's Law. And this requires healthcare facilities to allow the use of medical cannabis on their premises for terminally ill patients with a medical card or with a recommendation from their physician. So when they say terminally ill, this does not mean they have to be on hospice. Their definition is a 12-month prognosis. So California already has this law in place that they must abide by and that they have it to protect them. Okay, when looking at terminology and writing policies, these terms are super, super important because this is how the federal government has defined these things. Hemp means any product that comes from a plant that has less than 0.3% delta-9 THC. Marijuana is any product that comes from a plant with more than 0.3% delta-9 THC. So hemp does not mean that it's going to have low THC necessarily, because chemists have found a way to chemically convert CBD to THC. And these are products that can be found online, shipped across state lines, found at a gas station, or even, at CVS. This is where your Delta 8 and Delta 9 come in. But a lot of our patients can get what they need from hemp and hemp-derived products. Marijuana products are ones that come from a dispensary. And these you would either need a medical card or you would have to be in a legal state to obtain. All of these come from the cannabis sativa species. I have pictured here 2 hemp plants and 2 cannabis plants, but you obviously can't tell the difference because that 0.3% THC is an arbitrary number. But just knowing these terms is really important when writing policy. Okay, federal laws, as Rebecca said, cannabis is still Schedule 1. This means that it has no accepted medical use and high potential for abuse, both of which cannabis does not meet, both of which alcohol and nicotine do meet. But here we are. So it is federally illegal technically. In 2018, the Farm Bill was written, and this legalized hemp nationwide. Again, that's any product coming from a plant with less than 0.3% THC. This Farm Bill is being rewritten this year, so I think we're going to see a lot of changes with these higher THC hemp-derived products. Okay, in looking at the state laws, this was as of a few weeks ago. I see a headline almost every day of different states moving into medical or adult use. So the green ones are recreational and adult use. That means that any adult over 21 can walk into a dispensary, show their ID, and purchase products. Medical only means you have to have a recommendation from a physician and go through the state or the county's medical marijuana program. Illegal, these are states that are still living in the 1930s. However, these can be considered CBD only states where hemp is only legal here. We're hoping they catch up soon. Okay, what happens when your federal laws directly conflict with your state laws? So technically, there's something called federal preemption, and this means that the federal law is supposed to win out, and that's supposed to take over. However, how is that possible then, that we have all of these states that have legalized, but it's still federally illegal? So in 2013, Deputy Attorney General, Mr. Cole, wrote a memorandum saying that the federal government, the DOJ, is not going to spend its resources, prosecuting those complying with the state programs. In 2018, that was rescinded by Jeff Sessions. And in 2021, Merrick Garland kind of set it into stone. He said the Justice Department will not spend its limited resources, prosecuting individuals who are complying with state laws. So unless unless they find somebody an adverse finding like selling to youth or, aiding and abetting in drug cartels, they're not going to go after people who are complying with state laws. Okay, but what about Medicare? I know that's why a lot of people are here. So let's talk about it. How is it that cannabis is federally illegal? Medicare is going to come and pull our funds if we allow our patients to use it. Well, this is correspondence right here between the team that wrote Ryan's Law and CMS back from a couple of years ago. And they said the Medicare regulations do not address the use of medical marijuana or CBD oil. Surveyors look at topics such as medication storage, self-administration, safe smoking policies, and fire safety. There's nothing explicitly in the survey and certification process related to the use of marijuana or CBD oil. They generally require compliance with federal and state and local laws, but they would not cite this unless the DOJ has made an adverse finding. And they go on to say that they are not aware of any provider that has lost funding or been penalized for allowing their patients to use cannabis or CBD oil. So you have this document in place from CMS saying that they have never, affected or pulled funding because facilities are allowing their patients to use, and then they have no intention of doing that. They're far more concerned about that patient going into their 43rd hospice benefit period who has dementia than they are about the patients complying with their state programs. Okay, when it comes to the facility's role and patients' use of cannabis, of course, you want to be compliant with your state laws. If you are managing the patient's medication administration, you can have a physician order. This is not a prescription because you don't want a prescription for a Schedule I substance. Physicians can't do that, but you can still have an order giving direction for the med techs and the nurses to give the medications. Of course, the patient and the family would cover the cost. And then it's up to the facility then to kind of communicate with the family about needing refills and obtaining those medications. You want to look at safe storage and safe use. In California, they have to treat it like a narcotic and have safe storage for that. In staff education, you want your staff to be educated on medication interactions and side effects and adverse effects and know how to manage those. What about the nurses' rights and responsibilities? So 5 years ago, our governing body, the NCSBN, the National Council of State Boards of Nursing, wrote a 60-page document outlining the nurses' rights and responsibilities when it comes to medical marijuana and cannabis for our patients. I'll summarize it here in these 4 points. They basically said that nurses need to know their state and federal laws. They need to know about the endocannabinoid system and how cannabis works in the body. They need to know cannabis pharmacology and medication interactions. And then they need to know the safety considerations. They need to know what a low dose is versus a high dose, how to manage side effects. So nurses have this protection of our national governing body. When it comes to the physician's role, if the patient is using CBD or hemp and you are managing their medications, it's up to the physician to write the orders if they are knowledgeable enough. If not, then they work with a specialist to get those orders. If they're getting products from a dispensary, you can have the requirement that they need to have a medical card, and then it would be up to the physician to write the recommendation for that medical card to go through the state or the county program. And then, of course, have the physician write and sign the orders. Okay, so you have a patient who either comes to you, the family comes to you, or you think would benefit from cannabis or CBD. What do you do then? Well, you would definitely want to refer them to a specialist if you don't have somebody knowledgeable in-house. This could be a cannabis coach, a cannabis nurse, or some sort of cannabis clinician. There are hundreds of us throughout the country. And this is a specialist that works with the patient and the family and the physician. And they will help to write the appropriate orders. They would help to find the appropriate products and the appropriate dosing. Could you imagine the marketing opportunities here that you can advertise that you have a CBD specialist in-house or that you're contracted with one, so that somebody's dad coming in with dementia, he wouldn't have to worry about him being, sedated on hardcore antipsychotic medications all day. Instead, he can use his CBD oil and be awake, alert, and also calm, and maybe have an increased appetite too. Okay, so what about the employee use of CBD and THC? And I want to share Shonda's story. Shonda Broom was a Louisiana nurse. And back in 2016, she owned a business. She lost that business and she went into a deep depression. And she used cannabis to manage her symptoms of depression. When she was getting back into work, she failed the pre-employment drug screen. And then a month later, she passed that drug screen and was able to work. 6 months after that, she got a letter from the Board of Nursing saying that she was under investigation. So at that point, she basically had a choice to make. They said, you can go through this program. It's basically our narcotics program, treating her like a criminal. She had to pay for urine tests every month. She had to be basically babysat on the job in giving any sort of medications, and then go through this huge program and pay for it out of pocket too. And of course, not be able to use her cannabis to manage her symptoms. Or she could choose her mental health and choose to use plant medicine. And she ended up surrendering her license because of this. Now, in a time that we are so short-staffed, are we really going to, make nurses choose between using a safe and effective medicine or keep their nursing license and keep their career? But I know everybody's thinking, well, what about this drug-free workplace that's, this policy that's been in place for decades? So what drug-free workplace means is that it's any contract of over $100,000 annually from the federal government or any federal grant. This requires you to have a drug-free workplace policy and a drug-free awareness program. This does not mean that in your policy, you have to terminate for drug-related infractions. It does not mean that you have to drug test your candidates and employees and use that as a condition for employment. And as we know, many, many studies have backed this up, that THC in the urine is not an indication of impairment. Somebody can use and then still have it excreted in their urine for months after use. When writing policies, of course, you would want to get professional help. You'd want somebody on your team who knows this language and the importance of the different terminology, the different terms that we went over. Of course, you want to know your state laws and be abiding by your state laws. Medicare is all about safety of the patient. They're more concerned about this than they are about the Schedule I status of cannabis. And of course, educate, educate, educate. Your nurses should be going through annual education on cannabis and the endocannabinoid system. And your med techs should know, your med techs should know side effects and adverse effects of CBD and THC at the minimum. So here I have some examples of good policy versus bad policy. Good policy examples could say that the patient does not need a medical card for hemp or hemp-derived products. A bad policy example would say that patients may utilize CBD. CBD is just one compound of a plant that has hundreds of compounds in it. So this is both too broad and too narrow to be used as a policy. Another good policy would say that a medical card is required for patients using products from a medical dispensary. A bad policy is saying that patients may not utilize THC or marijuana, or that says patients may not inhale, or limiting the amount of THC. Because again, these are both too broad and too narrow. Another good policy could say that employees may not be under the influence or impaired by illegal or controlled substances while on the job. And a bad policy would say that would be using THC in the urine as a condition of employment. And of course, nurses must complete an annual training on cannabis and CBD, and the ECS would be a great policy to have. Okay, in conclusion, what if Ryan was your family member? What if Ryan was your uncle, your dad, your grandpa who had stage 4 pancreatic cancer? And in his final days and weeks was in so much pain. And with the current treatment, he had to choose between being awake, alert, and uncomfortable, or being sedated and comfortable and pain-free. Because with the current medications, that's the only thing that patients have to choose from. But cannabis is kind of this magical medicine that allows patients to be awake, alert, comfortable at the same time. And what would you want for your family member? Okay. And in summary, we're going to call it cannabis, not marijuana. Cannabis can be a safe and effective medicine. We are doing this for harm reduction and reducing polypharmacy. Medicare is more concerned about safety than they are about the Schedule I status. Employees need plant medicine too, and they deserve to be able to use it. And of course, work with an experienced professional to write your policies.